Hi, I'm Dustin Long. I'm a current T32 research fellow in the Department of Anesthesiology and Pain Medicine here at the University of Washington in Seattle in the Division of Critical Care Medicine. I got interested in research as a medical student doing work on the human genetic susceptibility to common viral infections. And over the course of my clinical rotations, I really developed a focused interest in critical care medicine and decided to pursue that through an anesthesiology residency training. And as a resident, I had the opportunity to research intraoperative factors, things that take place in the operating room, like fluid management, vent settings, opioids, and their impact on postoperative outcomes, both positive and negative things that occur following surgery as a result of decisions that we make in the operating room. I decided to come to the University of Washington for my critical care fellowship because of its excellence both in critical care and in genomics, and also because of the amazing support that exists for research within this department. I also love the people that I met when I came here, and as a critical care fellow, one thing that was really impressed upon me was the importance of healthcare associated infection as a common outcome that our patients face in the hospital on a regular basis. And so, entering into my T32 research fellowship, one of the factors that really motivated my work was trying to understand the pathogenesis of these infections and specifically the role in the patient microbiome as far as their etiology and development. Some of the work that our group is focusing on right now includes how surgical site infections arise fundamentally. Where do these infections come from? Are the bacteria from the patient or do they originate from the healthcare environment? And what's the role of pre existing antimicrobial resistance among these strains? We're also looking at how bacteria evolve over time and interact with the host to transition from states of colonization to infection following critical illness or major surgery.
One example of what this looks like is surgical site infection following spinal fusion, which is a devastating outcome when it occurs, and the microbiology is not necessarily what you would expect. It turns out that it varies across the length of the back, so from the cervical spine down to the lumbosacral area, the bacteria that are causing these infections vary dramatically. And so you can see down here over in the red on the right, there is this large bloom of kind of unexpected gram-negative flora causing infections among patients having spine operations low on their back. And this is something that's not accounted for in current prophylaxis, but perhaps should be. We also see that this varies dramatically between men and women. This is an important example of sex as a biological variable in medicine and represents a potential disparity in standard approaches to prophylaxis. And so we're now getting at this question, doing prospective longitudinal patient sampling and then subjecting these samples to bacterial whole genome sequencing and metagenomics to try to understand really what is the role of the individual patient microbiome in the development of surgical site infection in spine surgery and how we might be able to personalize our prevention strategies to improve patient outcomes. Some other examples of active projects include the role of Cutibacterium acnes, a common skin bacteria, in delayed shoulder arthroplasty failure. This is a big problem in this patient population, and we're hoping that we may be able to identify and decolonize patients with high-risk strains of this bacteria to improve their long-term outcomes. We're also using machine learning to try to detect surgical site infections in the electronic medical record in real time and use that to improve quality with better data and better physician engagement. We're also looking at Staph aureus respiratory infections and how Staph aureus evolves over time and evades our current treatment and eradication strategies using some genetic tools. And then COVID-19 has obviously been a major player in critical care and healthcare associated infection this year. And so this has presented an opportunity to work across departments to really use some cool methods to look at how SARS-CoV-2 is spreading both within hospitals and within our greater community. I would summarize my experience by saying both the clinical and research training at the University of Washington are excellent. Success as a physician scientist is dependent on excellent clinical training as a basis, and you will absolutely find that here in addition to excellent training in research methodology and career development. Support is excellent. There is time, there is mentorship, and there are resources to support your actual research. And beyond that, I've found the department is very supportive, not just of research programs, but they will be supportive of you as a research mentee, as an individual. Collaboration is a real strength of the program. There is a model in which you will be paired with mentors both within and beyond the department to really give you a scientific home, but also extend the reach of your scientific approach to other departments and other mentors, other leaders, to bring in new ideas and new technologies. And there really is a focus on your long term research success, not just your experience during your training, but there is an expectation that by the time you complete this pathway, you will have the tools and the experience and the passion to succeed in the long term as a physician scientist.
So, with that said, thank you for your interest in the University of Washington and our research training programs, and I hope we have the opportunity to meet.